Hello, my name is Colin Coyne, and as Executive Director of Meta Global, on behalf of all of my colleagues, we'd like to welcome you to this important and timely video presentation. Meta Global is a global education service provider that seeks to connect practitioners, educators, and institutions to deliver a transformative model of healthcare education. We seek to improve the outcomes of populations by providing access to globally renowned faculty in a way that addresses present and future needs and through the lens of competency, character, and caring. The series you're going to view today addresses the essential topic of cardiac complications from COVID-19. The series is divided into 6 parts, which can be viewed individually or consecutively as one seminar. We'd like to thank our partners at Brookwood Medical Health Systems and Dr. Farrell Mendelsohn for providing access to this content. We hope that it adds to your practice. We hope you enjoy the presentations, and we particularly wish you continued good health.
Hello, I'm Dr. Donald Lloyd-Jones, President of the American Heart Association for 2021 to 22. I'm also the Chair of the Department of Preventive Medicine at Northwestern University in Chicago. This presentation from the Cardiology PC Group in Birmingham, Alabama, on the CVD impact of COVID-19 should be very useful to you in your practice. I am so pleased that my former colleague from residency, Dr. Farrell Mendelsohn, was able to organize this series of presentations for your benefit. All the best to you and others in Asia as you continue to manage the COVID pandemic and the growing epidemic of cardiovascular disease. Enjoy the meetings.
So this topic is related to COVID-19 infections and the cardiovascular complications of that. But really, and I hope this pandemic is coming to an end, I think it is, the procedures and the approaches we use in these lectures really can be applied across many disease states that you'll deal with in your medical practice or we deal with here at Princeton. So it's just not COVID related, despite the fact that that's really the topic we're discussing today. Anyway, SARS-CoV-2 virus causes COVID-19 infection. It primarily attacks the lungs and causes acute respiratory distress syndrome. 14% of these patients end up in the ICU and 20% of those on mechanical ventilation. So it's a rough disease. And I'm not going to discuss the pharmacology of treating COVID-19. This will mainly be about the patients as we get consulted to see them. And from a cardiovascular standpoint, most of them have acute respiratory distress syndrome in various stages, usually towards the end. These patients are the sickest of the sick by the time we get involved. And just to go over some of the parts of their care that are going on before we get involved, this ARDS syndrome requires lung protective ventilation. Often these patients are in the prone position. These patients are receiving significant amounts of positive end expiratory pressure or PEEP. Most of them are paralyzed with neuromuscular blockade to prevent the ventilator dysynchrony that can occur, and almost all are on inhaled pulmonary vasodilators. Anyway, lung protective ventilation, we use lower tidal volumes. We try to optimize the PEEP so we can lower the FiO2. These high fractional FiO2s in the ventilator setting can be very toxic to the lungs, so we try to lower that as much as possible. And proning, we have patients who come in, they're so sick, literally we put them in the prone position on the ventilator. And what does this do? Well, it lowers the compression from the heart and abdominal organs on the lungs. It redistributes blood and airflow more evenly. There's less support from the ventilators needed to achieve the same oxygenation. Secretions drain better, and the blood return to the right side of the heart improves. There's less constriction of pulmonary blood vessels. So when the cardiovascular guys get involved, typically all this has already been done. All of these ventilator and oxygenation procedures are already in place. And we're basically called in at this point because the patient's going to die. He's on a ventilator, he's maxed out on everything, he's in prone position, he's paralyzed, PEEPs are as high as you can get them, FiO2 is usually 100%, and the patient is going to die unless something else is done. And that's where the topic of this lecture is, and it's called VECMO. And it should be considered for these patients who are refractory to all other measures in the acute respiratory distress syndrome due to COVID-19 pneumonia. So what is VECMO? The VV stands for veno-venous, and that means that blood is removed from the venous side of the circulation and it's returned to the venous side of the circulation. And it's taken outside the body. That's extracorporeal. And membrane oxygenation, basically, we have a membrane lung. And this device, this oxygenator, not only oxygenates the blood, but it has a counterflow sweet gas, and by the engineering of this oxygenator, literally removes CO2. So basically, we just take the lungs out of the picture. And we do it with this device, VECMO, and this procedure, VECMO. And basically, we can oxygenate the patient's blood and ventilate the patient by removing CO2 outside the body, and then the blood's returned to the body. So, to describe this once more, we remove a portion of venous blood, push it through a membrane oxygenator or a membrane lung. The blood is oxygenated. Carbon dioxide is removed by counterflow of a sweet gas. The blood is then returned to the right atrium by a centrifugal flow pump. Lung function is basically replaced. This allows for resting ventilator settings. This significantly decreases the ventilator-induced lung damage, so the lungs have time to heal. This virus, this COVID virus in particular, just wreaks havoc on the lungs, literally just chews them up. So we try to avoid any other damage we can, especially that you encounter with a ventilator. Like high levels of FiO2 cause lung toxicity, as do high levels of PEEP. So how do we gauge where we are in this scenario when we see these patients in the emergency room or they're referred in to the ICU from another hospital? And typically this PF ratio is a good way of doing that. And the PaO2 is the ratio of our arterial oxygen partial pressure measured in millimeters mercury to the fractional inspired oxygen, usually at this point provided by a ventilator, and that's a fraction. So in ARDS, 200 to 300 is mild disease, 100 to 200 is moderate. Anything less than 100 is severe ARDS. And if you're at an outlying hospital that does not necessarily have ECMO capability and you have a patient with a PF ratio under 100, and that patient is a candidate for ECMO, and I'll go over that in a minute, you need to seriously consider moving them to an ECMO capable facility because that patient can go downhill in a hurry and die. And remember, O2 toxicity is when the FiO2 is greater than 0.5. So if you read our literature, the American College of Cardiology positions on using ECMO in COVID-19 pneumonia and ARDS, they give some rough guidelines, but these are just guidelines, and there's more of an art to it, and there's some nuances we've discovered here at Princeton which alters this equation some. But in general, when your PF ratio is less than 60 for 6 hours, you need to start thinking about ECMO. When the PaO2, FiO2 ratio is less than 50 for 3 hours, same thing, or the pH 7.2 with the PCO2 greater than 80 for 6 hours. These are all just rough guidelines that we need to start thinking about ECMO, VECMO in the case of ARDS. So what does this look like? And I'm going to show this, how we set these patients up. So in ECMO, we have a venous drainage cannula and a venous return cannula. This is in VECMO. And we do venipunctures, in this case, on both femoral veins. A guide wire is used then to place into the right atrium or superior vena cava, in this case, from the left femoral vein. We have a drainage cannula, which you can see on the right, just above the level of the hepatic vein in the inferior vena cava. That drains blood out. It then passes through our centrifugal rotary flow pump, which pushes the blood to an oxygenator. And in that oxygenator, the blood is our membrane lung outside the body. The blood gets oxygenated, but there's also a counterflow sweet gas, which removes CO2. So basically, we have a tiny lung outside the body, which is doing everything the lung would do otherwise if it weren't so diseased with COVID-19. Then the blood leaves the oxygenator and goes back to the body, this time through the right femoral vein, which we've cannulated with a return cannula. These are both 24 French cannula. They're big. You have to understand at coronary angiography, we use 6 and 7 French devices, and this is 24. It's a big cannula. So the blood leaves through our drainage cannula. It goes through our rotary pump to the oxygenator. The blood is oxygenated, the CO2 is removed, and then it's placed back in the body in the right atrium. All this is done outside the body. Extracorporeal. And here's another way this can be set up. It's really the same thing. The drainage cannula is placed through the left femoral vein here into the inferior vena cava, just above the hepatic vein. Blood is taken out of the body, a portion of the blood. It's then pushed through the rotary flow pump, or the rotary flow pump takes the blood, moves it to the oxygenator, and then back through, in this case, through the internal jugular vein. You can see the return up here, internal jugular vein, and back to the level of the right atrium. So blood is taken out of the body, oxygenated, CO2 removed, and then placed back in the body. Takes over the function of the lungs, allows the lungs to heal off or very low ventilator settings, lung protective ventilation. So some smart guy decided back there at some point, why have these cannula going through the femoral veins or femoral arteries? Why not have one large cannula and have both the inflow and outflow cannula going through the one large cannula? And a device called a Protect Duo was made. Now this is no small cannula, as you might imagine, because we have 2 lumen in it. This is 29 French, 31 French. 31 French in our larger patients, 29 in the smaller. This is a very large cannula. We put it through the internal jugular vein using a very stiff wire called a Lunderquist wire. It's like a coat hanger, basically. You have to have experience before you do this because it's pretty involved in terms of placing this very stiff guide wire, but it has a soft tip out in the right pulmonary artery, hopefully. And then the cannula is moved over this into position with the distal end of the cannula being in the pulmonary artery. You can see here, that's the outflow. The inflow or drainage part is in the right atrium. So basically you're taking blood out of the right atrium, taking it outside the body through a centrifugal rotary flow pump, which then pumps the blood to the oxygenator, oxygenates the blood outside the body, and then a counterflow sweet gas moves past the blood in the opposite direction inside the oxygenator and basically removes CO2. All the function of the lung done outside the body, now through one stick through the neck in a large cannula that basically takes the place of the devices we were having going through the leg. And why is this important? It's important because now, and I'll go over that in a minute, but let me just show you this one other slide here, which I think shows it much better. Here are the 2 cannula now involved in one encapsulated in one cannula, which enters the right internal jugular vein. The distal end of this cannula is placed in the main pulmonary artery. You can see it here. The inflow part of this cannula rests in the right atrium. Blood enters the inflow section, is removed from the body, goes out to the oxygenator, CO2 removed, blood's oxygenated, and now back in through the other lumen into this 31 French cannula, and then that blood is deposited in the pulmonary artery, basically taking over the function of the lungs outside the body. And why is this important? This approach to VECMO in our COVID patients, this approach was really pushed through at Rush Memorial Hospital in Chicago. And our intensive care team and our group of interventional cardiologists here quickly figured out that this provided a lot of advantages. So by using the Protect Duo cannulation through the right internal jugular vein to the pulmonary artery, you have direct pulmonary artery flow and improves oxygenation and ventilation. And very importantly, early mobility of the patient once off the ventilator. So our whole job of using this is try to get these patients off the ventilator. COVID-19 is wrecking their lungs. The ventilator only worsens that. So we go to these lung protective ventilation parameters I mentioned earlier, but still, we want them off the ventilator as soon as possible. COVID-19 is doing a job, let's don't add to it. So by having this device in their neck, this Protect Duo, we're able to mobilize them, have them sit up, have their diaphragm be part of the ventilatory effort at a much earlier stage. Also, there's minimal cannula-associated complications or revisions, which is dissimilar to the bilateral femoral approach. And we have support of the right side of the heart in case of right ventricular dysfunction. In fact, we use this very cannula when we have big right ventricular infarcts after myocardial infarction. So here's a patient, he's 57 years old, and I did this cannulation. He came in from another hospital. At the other hospital, they had him on BiPAP, and his PF ratio was 37. And then he was intubated, and the PF ratio I mentioned earlier, anything under 100 is severe. His was 65 on the ventilator. He was not looking good. His chest-X ratio classic ARDS with COVID-19, and he was sent here for ECMO. And Dr. Crane, our intensive staff, called me. We took him up to the cath lab and put in ECMO. And that night, later that night, I was talking to Mike, and he had been extubated that very evening. The next morning, I went in and made rounds, and I asked him, do you mind if I take a photo to show for this conference I'm going to give in a few weeks? And you see his thumbs up. So the reason I show this is just a real photo of the diagrams I just showed you. That is a Protect Duo 31 French cannula in his right internal jugular vein. You can see the pointer on it. It then comes out, and there's the outflow or drainage cannula going into this centrifugal rotary flow pump, which then pumps in. We had dual oxygenators on him, but then both oxygenators connected. And this little green line is the sweep gas. And the sweep gas I mentioned earlier, it's counterflow, it removes carbon dioxide, and you can see it coming in here. And then this is the return cannula. It then goes back through the Protect Duo and delivers blood into the pulmonary artery. This is another patient, Dr. Saab, my younger partner, did this case. And this fellow, 33 years old, and he actually walked into the emergency room. He lives about 4 blocks from Princeton. Walked in, he looked like he was on death's door. He was placed on BiPAP immediately. The highest oxygen saturation they could obtain was 50%. The patient was intubated, sent up to MICU, and Dr. Crane called Dr. Saab and said this guy needs to be on ECMO immediately, and put this Protect 31 French cannula in, and we started ECMO immediately. And he was extubated 4 days later from the ventilator. And then Rand was out of town. I decannulated this on the 22nd, 10 days later after his admission, and he was discharged 2 days later. So he was in the hospital a total of 12 days, but without ECMO, I think this patient probably would have died. He had such severe pneumonia and ARDS and was in terrible respiratory failure when we placed ECMO. And this is just to show you what this looks like from the side view. So here's the Protect Duo cannula. This is the drainage part of it, the drainage lumen into the rotary flow pump to the oxygenators where the blood's oxygenated, CO2 is removed. This is the controller we look at. Now when we first put this in on him, we had flows of 4.5 liters per minute and the RPMs was around 6,500. But now we were getting close to decannulation, so we had ramped everything down. But this is the control module that not only controls the amount of sweep, so how much CO2 we're removing, but also how fast the motor's moving to oxygenate the blood. So we can control oxygenation and ventilation outside the body with this device. So we're going to leave VV ECMO for a moment and go to VA ECMO. So what is VA ECMO? That's veno, arterial, extracorporeal membrane oxygenation. Veno, the blood is removed from the venous side of the body. Arterial, the VA part, the blood is then put back into the body on the arterial side. And this is in the setting of shock or massive pulmonary embolism or both. A portion of the venous blood is removed from the inferior vena cava. Our rotary flow pump pushes this blood through a membrane and oxygenates it. We have the counterflow sweep gas removing CO2. The blood is then returned to the arterial circulation in the distal aorta. So basically we're supplementing reduced cardiac output in a failing heart, and we're supplementing it with oxygenated blood. And here's a diagram of this. We have a 24 French cannula in the inferior vena cava above the hepatic vein, placed through the right femoral vein using standard venipuncture techniques. The blood is removed through the rotary flow pump to the oxygenator. CO2 is removed, blood's oxygenated, and then returned to the left femoral artery, and that's a 17 French cannula we put in the distal aorta. So here, not only are we supporting the lungs with oxygenation, we're also supporting the heart by providing cardiac output. So what are the cardiovascular manifestations of COVID-19 that produce shock? Well, first of all, just the sepsis from the virus itself. A myocarditis, because this virus can infect the entire heart muscle. A stress cardiomyopathy can occur, such as in Takotsubo, where you had this adrenergic release in this very sick patient, which can stun the heart and put the patient in cardiogenic shock. And then the hypercoagulable state. We can have massive thrombosis in the pulmonary arteries, causing shock, or in the coronary circulation itself, causing myocardial infarction and shock. It's important to start VA ECMO prior to irreversible multi-organ failure. We want to get this in the hemodynamic phase, not the hemometabolic phase. So what are indications for VA ECMO? Refractory cardiogenic shock with persistent tissue hypoperfusion. Basically, blood pressure is hanging out under 90, cardiac index under 2.2 liters per minute per meter squared, and this is on pressor and inotropic support. So let's talk a moment. So we've talked about VV ECMO and now VA ECMO. The majority of these patients are going to be VV, but we do run into VA. But what about the VV patient, the VV ECMO, who is in respiratory failure? We're treating them and getting good results, but then they develop shock and they require VA support. Then we can transition them to VVA ECMO, veno arterial. We have a single venous drainage cannula, 24 French, sitting in the inferior vena cava. The blood is then pumped to an oxygenator, CO2 removed, blood oxygenated. But here, on the exit from the oxygenator, the blood return is then split. We just basically take a drainage cannula, go into the femoral artery, through a 17 French cannula. So now this blood flow out of the oxygenator is split return to the venous side and the arterial side. So we're doing everything. We're oxygenating and supporting blood pressure in a patient who previously was only on VV, but now developed shock, and we can go VVA, veno arterial ECMO. And here's a picture of it. You can see the 24 French drainage cannula in the inferior vena cava, just below the right atrium, draining the blood into our centrifugal rotary flow pump to the oxygenator. Counterflow sweet gas removes CO2, the blood's oxygenated, leaves the oxygenator, and then split return to the distal aorta for cardiac output support and back into the right internal jugular vein to provide oxygenation and CO2 removal. So now the final part of this, I think, is probably one of the most important parts, and that is, who is a candidate for ECMO? And believe me, we've seen it all transferred in, and this is not for everyone because it's very resource and equipment and time intense. So relative contraindications would be a patient over the age of 65, a BMI over 40, immunocompromised, no legal or medical decision maker around, advanced heart failure, and they're on high-dose vasopressors without being a candidate for the VA portion of this. Now, absolute contraindications for ECMO. You want to avoid it if there are a lot of pre-existing comorbidities or several comorbidities. If there's uncontrolled bleeding, if there's an inability to be anticoagulated, inability to accept blood products. And really the patient must have a reasonable chance of long-term survival after the resolution of their COVID-19 infection. Other absolute contraindications: advanced age into the 70s or above, clinical frailty score 3 or greater, mechanical ventilator greater than 10 days. And we see this a lot. We see a patient at an outside hospital who's been on a ventilator for 12 days or so, and it looks like they're not going to make it, and we get called, can this patient go on ECMO? At that point, the lungs are so severely damaged, placing on ECMO will probably be futile. Also, severe multi-organ failure, severe acute neurologic injury are also absolute contraindications. So what are these significant underlying comorbidities we need to be aware of? Chronic kidney disease, stage 3 or greater, cirrhosis, dementia, neurological disease without chance of recovery, disseminated malignancy, advanced lung disease, uncontrolled diabetes with chronic end organ dysfunction, and chronic malnutrition or deconditioning. All absolute contraindications. Now in our world, anytime we start an acute mechanical circulatory support device, whether it's a balloon pump or Impella or ECMO, we need to have a destination out there. And using ECMO in these extremely sick patients, it needs to be known up front that we, at some point, the patient either does well, comes off ECMO, and goes home. Unfortunately, we have a bunch of those. But in the case where the patient is not doing well, and believe me, the mortality rate in this country using this approach is 50%. Okay, so these are very sick patients, and many of them do not live. So you need to have the discussion with the family up front, prior to cannulation, prior to even being put on ECMO, that at some point we may have to make the decision to come off of it. So what is futility? It's the absence of hope for a healthy survival in this patient. It could be severe brain damage, it could be irreversible multi-organ failure, and in the absence of heart or lung recovery, and there's no option out there like a durable VAD, and that's an implantable ventricular assist device, or a heart transplant or a lung transplant. In the absence of any of that, futility may be staring us in the face. In our VA ECMO patients, if they've had no cardiac function for 3 to 5 days, that's pretty much accepted. That's a futile situation. In VV ECMO, no lung function for 2 to 3 weeks, but that, and all the intensive care guys here will tell you, that's become very blurred. We've had patients on ECMO for 30, 40, even 50 days who have gotten better, their infections resolved, they were decannulated, went home, and now have meaningful lives with their family. So that second part, when do we declare it being a fetal situation, is a lot more blurred now. So our last slide, I want to present to you our data and the national data. So ELSO is the Extracorporeal Life Support Organization. It's nationwide, and we're a member of that. It's a live dashboard of all reported cases of COVID-19 patients on ECMO. Basically, they look at all ECMO, but there is a subcategory of COVID-19 patients. And ELSO started recording this at the beginning of 2020, and now through just recently, this is the current data. Total cases nationwide, 5,096, and with 1,823 deaths. That's a 48% mortality nationwide in COVID-19 ARDS on ECMO. At Princeton, we've had 42 cases, 12 have died. That's a 29% mortality. So at Princeton, we've had a 40% reduction in mortality compared to national data. And I must say, I have to give credit to our great intensive care team, Mike Crane, Ronnie Roan, Josh Smith, Amanda Hopkins, and all the PAs and NPs who work with them. They're incredible. Our cardiovascular team, who does the cannulations and decannulations and follow these patients while they're on ECMO. But I think the real, it's a team effort. And I have to give the real credit to the group of nurses in MICU, because I deal with them every day. And when we first started doing this, ECMO was just done in our CICU. And we had to send our CICU nurses down to the MICU to help with these devices. But the crew down there took on the job of learning how to do ECMO and everything involved in it. And those MICU nurses, I call them my COVID Ninja Warriors, because they're incredible. They truly have taken on the job of caring for these extremely sick patients and learning how all the nuances of ECMO and everything involved in it. And they really are just very enthusiastic about the care of these extremely ill patients on very complicated support. So I want to give them all the credit in the world for that. Any questions? Okay, thank you.
I'm pleased today to bring a brief summary of the presentation you've just watched on the cardiac arrhythmias associated with COVID-19. The cardiac complications of COVID-19 are numerous and include myocarditis, reduced left ventricular ejection fraction including heart failure, left atrial enlargement, right ventricular dilation, pericardial infusion, and of course myocardial infarction from thromboembolism. We see common lab findings in patients with myocardial complications of COVID-19, almost always increased troponin levels, and we see the usual cardiac arrhythmia complications associated with non-COVID related heart conditions, including cardiac arrest, atrial fibrillation, bradyarrhythmias, and ventricular tachycardia. Much has been studied about the management of arrhythmias in patients with COVID-19, and generally, as you heard in the presentation today, the same approaches that we take in non-COVID patients to manage these arrhythmias as they arise with cardiac complications of COVID-19 should be used. So use your guidelines for management of these cardiac arrhythmias. So as you continue to care for your patients with COVID-19, I know you'll use your clinical judgment to make the best decisions for them, and we wish you well in the care of your patients. Thank you so much.
Greetings, my name is Dr. Charlie Sands, and I serve as chair of MedEd Global's advisory board. As an international medical education service provider, MedEd Global is excited to have provided this outstanding review of the cardiovascular complications of COVID. Our mission is to promote superior education and training for international healthcare personnel. I sincerely hope that this educational video has proven to be of help to you and your colleagues. If you'd like to discuss ways in which you can support or become a part of MedEd Global, our contact information will appear on the screen momentarily. Thank you for the opportunity to share this important information on the cardiovascular complications of COVID.